Northampton County Human Services Committee meeting. First item on the agenda is courtesy of the floor. The second item would be the update on Graysdale. Always well-attended committee meetings today.
No such thing.
Okay, as usual, I'll start with admissions. Our admissions has reached a pretty much all-time high of 671.5 for October. Today we are 670, but of course we're getting into admissions today and another 2 tomorrow. If we look in terms of 2016, we're up 3.3 in our admissions. Bed hold days, we're at 4. Pretty much higher than we were in 2016. Let's see what else we have. We also, if you take a look at our Medicare ADC, we are up to 28.4 from 28.1. We're slightly down from 2016, 1.1, not much. And are there any other questions with regards to the numbers in admissions? No? Okay. I'll go into finance if that's okay. Our cost per resident day went down a little bit in October from September. It's still higher than our 2016 when compared at $32.11 higher than a year ago. Year-to-date cost per resident day is $272.47. We're up $15.16 from 2016 when you compare. And our days in account receivable is at 113. We're up 8.2 days. However, just to let you know, we had 6 individual cases where we did issue a 30-day notice for non-payment, and all of the 6 cases, 4 of them paid and 2 are on Medicaid and moving in the right direction to get Medicaid, so we are going to get payment for them. So that should be bringing down our account receivable numbers for November. And our Part B revenue is $137,000. Oh, I'm sorry, I went down too far. Sorry, didn't mean to do that. MA case mix index is 0.93. It didn't count in 2016 because they weren't measuring it, but again, we did start at 0.8, and now we're at 0.93, and we'll continue to move up to 1.0. Okay, Medicare. If there's no other questions in finance, can I go on? Oh, yes.
Yeah, I guess we're getting close to the end of the year. Are you able to make any projections as to where we're going to be as far as breaking even, having a surplus? Any thoughts on that? We're a month and a half to go.
Yeah, I mean, at this point, we're definitely going to break even, if not make a little bit in the black. We should be okay. I don't want to say exactly what, but we are definitely doing well, and should be definitely in the black like last year.
Good.
Okay. Any more questions before I move on to Medicare reimbursement? Okay. If you take a look, we're at 522.04, a little bit lower slightly than last month, but up higher than in 2016, up by about $26.16. Our average net per diem is a little bit lower at $424.71, but we are higher than we were in 2016 of $35.94. And our Part B revenue is at $137,657. We're down about $8,004 from 2016. Any other questions in finance and Medicare reimbursement? No? Okay. I'll move on to nursing. All of our nursing overtime has decreased in the last month, as you can see. We are actually, probably about anywhere from 200 hours to 600 to about 2,000 hours. And I can tell you, with regards to the CNA, we're really down in overtime because we had probably about 12 one-to-ones, which we have reduced to 4 in that month. And we continue to reduce our one-to-ones. You know, as people come in, sometimes they will require a little, a one-to-one because of behavioral reasons, but we are able to bring them in and try to wean them off the one-to-one throughout their stay at Graysdale. So that's that. And our agency, it remains the same only because it's an approximation while waiting for all of the October agency invoices to come in. But we have been steadily going down, and when you compare it to 2016, we are down $34,591 from LPN agency, but we're up $3,302 CNA agency only because we didn't use CNA agency in 2016. Any other questions regarding nursing before I move on? Okay. Page 2. We had one complaint visit, and it was unsubstantiated, meaning we did not receive any deficiencies. So we were doing very well with that. Any other questions or compliance risks before I move on to quality measures? Okay. Quality measures, we're very slightly up, like 0.1 on falls with major injury. Our short-term pain is slightly up from 13.8 to 18.9 due to new medically compromised admissions coming into Graysdale. Our long-term pain is slightly up from 5.7 to 8.7 due to progression of illness for our existing residents. Our restraints remain the same. In November, you're going to see a drop because we just dropped another 3 residents in restraints. So that should see a further decrease in restraints.
And what are you doing to allow the drop in restraints?
Well, our assistant director of nursing is really monitoring the restraints. She is in charge of them. She constantly looks at them and sees where we can reduce a restraint. And usually it's because the individual begins to deteriorate and they don't need the restraint as much, so we're not going to keep it on, of course. So that's what we're looking at with the individuals who do have restraints. Yes.
We are lowering the number of patients that need restraints, and we're lowering the number of patients that need one-on-one care. Are we changing our admission standards? Is that anything to do with how we're changing our admission standards?
Well, no, we're not changing our admission standards. We continue to accept our residents with different types of conditions. The only resident we cannot accept is a danger to self or others initially. What we're doing is we're working effectively to try to, if they come in with different conditions or a high number of medications or things like that, we're trying to reduce those medications and try to reduce the behaviors as well. So this way, we can reduce the amount of one-to-ones that we have. And it's basically just spending more time with them. Hospitals are a little bit different. They do have things like posies and stuff. We don't have that. So we have to be more, creative in what we're doing to try to help the residents, come off certain restraints. Oh, I'm sorry. A posy is, there's different types, but the posy that we're used to is a vest restraint. And it's something, or sometimes mittens, in hospitals when they have to. They're allowed to use those. We can't. In nursing homes, those are all considered restraints, so we don't even have the opportunity to utilize that.
What happens when this can't come in because of danger himself or something like that?
Well, I mean, in a situation like that, we can only take someone if they're stabilized. If they're able to stabilize them on medication or to show no signs of behaviors for 7 days plus, then we will definitely go look at them and consider them. But if it's like chronic, then no one is really going to be able to take them. They're going to probably remain in the hospital until a situation changes where they can come into a nursing home. Okay. All right. We're slightly, let's see, we're slightly up in weight loss, not much, 0.1, but we are 1.3% increase from 2016. We are slightly up with regards to our pressure ulcers, but again, that is also from the number of residents we've been getting coming in with pressure ulcers and us trying to heal them and reduce the amount of pressure ulcers that they had. So we are reducing that. And of course, our facility acquired raised a little bit, but that didn't raise too much. We do have some residents who do have multiple pressure ulcers, and they count each ulcer, not each person. So that's why it seems a little bit high. And our infection control rate came down, and also our facility-acquired infections came down as well. So that's good. Any other questions with regards to quality measures? Yes.
How long is the record of measurement the impact, and do you think if that is going to be a measurable difference in the future?
Oh, yeah. Well, she came to us, I think it was July, right? Oh, I'm sorry, July. Time's gone so fast. And she's been fantastic. I mean, she really looks at everything with a critical eye. You know, she will go ahead and walk the units and see what's going on with the residents and with the staff and try to make improvements. And she really has made a lot of improvements in such a short time. And we're very excited by her and the work that she does, and very happy to have her. So she really gives you some food for thought, so to speak. I mean, things that she does and she says, you know, how we approach things. She's just really giving us a fresh, objective eye. Thanks. So any other questions with regards to quality measures? No? Okay. Satisfaction survey, we're doing pretty well. We're at 4.11. We're a little bit lower than 2016, but we're still over the average score of 3, which is good. Our sick call-outs have increased slightly from 126 to 160. They're a little bit higher than 2016, about 8. Turnover, we continue to have 0 turnover for our RNs. Our LPN turnover only increased slightly to 2%, and our CNA is increased slightly from 2.1 to 3.4%. And of course, very good news is in our CMS star rating is that we're now overall a 3-star. Our health inspections are a 3, our staffing's a 3, and our quality measures continue to be a 2, but we're working on getting that up as well. So that's my report. Does anyone have any questions? Yes.
For human resources, who Edwards retired
November 1st, yes.
So do any, what is that replacing her? Can you talk about that?
Well, I know it's a process to replace Sue. You know, she's been there 26 years, and she's definitely someone who is a staple in our facility, and we are working to go ahead and replace her in the future. It's me. Yeah. Oh, yes, please.
Good afternoon, Council. I think for Mr. Phillips, it's hard to have somebody fill in as an assistant nursing home administrator because of licensure and requirements that exist. So Mr. Soto's filling in. We have worked to update the job description so that we have something that's current, and it is posted, and we are getting applicants as we speak. Okay? Any other?
Yeah, the licensing, that's under you, it's under Premier, isn't it? It's not under,
They each have a license.
Yeah,
He-
my own license.
He has a license. The assistant administrator would have a license, just as every RN has a license and LPN has a license.
I guess I'll put it this way, when Dean left,
Not on our end.
Yeah, we were okay because Sue had a license.
They have a license.
Yeah, they did, Sue, even though she
Right.
doesn't have a license, they did send in an interim administrator from Premier who has a license as well. Yeah.
Yes. And the facility also has a license.
Yeah, but I was talking about administrator.
Okay.
Okay, any other questions?
Yes.
I think it was last month or the month before, we had an emergency approval of some repairs to the kitchen. Can you update us on that? Has that been resolved, and is everything?
Yeah, sure.
Only because I've been involved in it. The kitchen floor, the first phase is done. The knee wall was finished. Everything was in good shape. So I know that they're waiting now till after the holidays to finish the phases of the floor because of the amount of meals and the amount of people that they have to feed each day. So they have walls in different places where the dirt and stuff cannot go, but they are going to wait until after the holidays. So yes, the emergency thing worked out very well, and all of everything is, the steam is going back down where it belongs now instead of internally, which is very detrimental to your walls and such.
But the project will continue into next.
Oh,
next
absolutely.
year.
This is a large, large project to do that kitchen floor.
Okay, thank you.
You're welcome.
Okay, are there any other questions? Okay, thank you very much.
Okay, thank you, Mr. Soto. Next, we're going to be moving on to the update on the drug and alcohol division. Thanks.
Good evening. I'm Tiffany Rossines, for anybody who doesn't know me. I'm not sure what you want an update on, so I'm going to focus on the hot topic, which is the heroin epidemic, and talk about what we're doing in our division for that. So in 2016, there was 70 overdose deaths in Northampton County, and halfway through this year, the coroner reported that we were at 53. I haven't gotten an updated number from him, but he anticipates we will surpass that number from last year. So what the state has done, they applied for a grant. It's called the CURES grant. It's $26 million that they received, and they split it amongst all of the SCAs. So we received a letter, we've received the funding for it, and then there's certain things that we can do with it. So I'll just talk about what we're doing with our money, what we're planning to do coming up that we haven't started yet. The first thing is prevention. I'm a huge proponent of making sure that we are out ahead of treatment. Everybody talks about treatment, but we need to start before treatment. And our biggest project we just started is a collaboration with Lehigh County Drug and Alcohol, the Center for Humanistic Change, and the Patriot League. We're working with Lehigh and Lafayette College to do a whole heroin and opioid campaign. And in that packet I gave you, the color photo, this is one of our messages that's posted. We were just at the Lafayette game on Saturday. We were at Lehigh a couple weeks ago. We're going to be at wrestling matches, basketball games, and lacrosse. And this is kind of the message they're putting out there. So we're going to have signage. We're going to have electronic billboards. We did on-air interviews. We did radio, TV at the Lafayette game. And this gentleman that's on here is Joe. And Joe is a graduate of the Northampton County Drug Court. So it's pretty neat to have him on there. He spoke on Saturday on TV and talked about what drug court did for him. He's also a master's student at Lehigh University. So he's showing kind of, you can turn your life around and here's what you can do. So we're very proud of Joe. And so this will be featured all over. Our county, it's not on here, but in the programs and everything, the county seal is on everything so they know that we're sponsored the event. And we've been out on the field and introduced and our numbers out there. The second thing we're doing is the HOPE program, which I've talked about before. It's the heroin and opioid prevention education. So it's an informative program that we do in the schools, in the community, but then we also have either individuals in recovery, or a lot of times it's parents of those who have lost someone that come and speak to kind of give the human touch to the program. It's being revamped right now, and they're calling it HOPE 2, and HOPE 2 is going to feature many Northampton County residents. So we're pretty proud to have that taken on. A lot of them are our drug court participants who have volunteered to share their stories. Their parents are speaking in it. It'll also feature one of our participants who unfortunately overdosed, and we lost him, but his story was captured before, and then they'll talk about the downside of addiction. The other big topic in the state is a warm handoff. We have worked tirelessly with the hospitals to make sure that if someone comes in and they've overdosed, we don't want them back on the street. We want someone in there that can get to them, can assess them, get them into treatment, because when you have them captive, they're engaged, that's the time that we need to do something. So we have partnered with Mid-Atlantic Rehab Services, we call them MARS, and they have the HOST program, and in your packet is an FAQ. It just tells you more about what HOST does. It's been revised because we've added our hospitals here, but they have someone 7 days a week, 8 a.m. to midnight. There's a dedicated phone number. The hospital calls, says we have an individual here. The host worker will go to that hospital, meet the individual, talk to them about treatment, getting help. They'll do a full assessment on them, and if they are still willing and able to go, we'll make referrals into treatment. If treatment's not available, they'll link them to community resources, and they'll follow up with them until a bed is available. It's been a little bit of a slow start. Some hospitals call, some don't. So we have constant dialogue with them. We just got Easton Hospital on board. We're working on a memorandum of understanding with them so that we can start having hosts go there as well. And this is a joint collaboration with Lehigh County, so between the two agencies we're funding this whole program. But it has worked when they use it and when they call. And we've had, in October, there was 171 referrals between the two counties. A majority of the county hospitals are in Lehigh County, but our residents are all over the place. So we've come up with joint data together. Of the 171 referrals, 146 individuals actually were seen. We have some that just say, no, I don't want it, get out. We have some that we see and then they don't go ahead with treatment. That happens. But year to date, we're at 760 referrals, and that's with one hospital still missing. So it's a great program. It works when it works, and we just keep tweaking it. We also have the host coordinator going in and educating doctors, nurses, social workers on addiction, on what to do. St. Luke's has been great about kind of holding on to people. I know they have to get them in and get them out. We do the best we can to get there as fast as we can. And the ultimate goal is going to be to expand from 20 to be 24 hours and add more staff, rather than there might not be such a delay getting somewhere because they're tied up here. But we'll take anybody, private insurance, no insurance, and the host coordinators will help them get insurance. We'll start the MA process. We'll do all that. And then the county workers are informed on, the next business day, so that we can also follow up, because my case managers then do a lot of case management and outreach to them. So that is host. Another thing we have is, and it's been in the news, and there's a press conference today, so tune into FMZ and you'll see us there. The Northampton County Heroin Overdose Task Force, and this was started with the Bethlehem Health Bureau. It was originally a joint collaboration with Lehigh County. We ended up kind of splitting apart, and we've done our own thing. And what we started is the B-Pair program, and there's, I gave you the Bethlehem handout, but there's also a B-Pair program in Bangor, We took a big city police department and a small town police department, and we're piloting this program. And basically, anybody can walk into the police station Monday through Friday, 8 to 5, and they can say, I want help. They don't have to worry if they have paraphernalia on them. They will confiscate it. They don't have to worry about arrest. This still will run there to make sure there's no active warrant, because we cannot put anybody into treatment who is actively wanted by the police. But if they're not, they're good to go. Lehigh Valley Intake will come to the police department. They'll do an assessment. They'll refer them. And we've had 3 so far in Bethlehem. They just started fully in September. All have gone into treatment, so 3 for 3. Bangor's doing more of a soft rollout. If someone goes in there now, they'll take them. But January 1st, they plan to be fully operational. And again, Lehigh Valley Intake will send somebody up there, same process. And we're in the process of writing a grant to expand the program to the other police departments, because we've had a lot of interest. Portland wanted to be a part of it.
So this is kind of neat, because, you know, the primary place that I think people approach their addictions is the hospital, right? So they go to the ER and they're like, I need help.
Mm-hmm.
This is kind of interesting that the police departments are opening up their doors, and I'd be surprised to see how much they actually confiscate during these initial encounters.
And I believe we'll keep tallies on all of that. This is actually, if you've ever heard of the ANGEL program, Gloucester, Massachusetts started it. This is what we based our program on, and there's over 100 of these programs now in the country. So to have 2 in our county is pretty neat.
Yeah.
But I mean, so far so good. We've trained 150 police officers or more on addiction, signs, symptoms, what to look for. We have Lehigh Valley Intake went out and did all that. So we kind of have been doing a whole setup, and Chief DeLuzio from Bethlehem and Chief Felchuk from Bangor, they have been excellent, on board from the start. They're at all our meetings. They're very pumped up about doing it.
So I have a couple questions about this.
Sure.
So if somebody comes into the police department and says, I have an addiction and I need help, it says here that they're not going to be arrested and they're going to be set up with an addiction counselor. Is that correct?
So what will happen is when they come in, they need help, they are going to run them. If there's no warrant, they're not going to be arrested if they have drugs on them or any paraphernalia. If there's a warrant, that's they have to resolve that.
Right.
So say he comes in, there's no warrant, drugs on him, they're going to confiscate the drugs. And then what they're going to do is call, there's a phone number, and it calls Lehigh Valley Drug and Alcohol Intake, who's our assessment provider for the county. They're going to send somebody to the police department who's going to do an assessment, determine, a lot of times they need, inpatient rehab. They're going to sit there with them, make the phone calls to the rehabs. They said of the 3, 2 they were able to get, I believe, the same day. 1 could not get in that day, so they had, we have certified recovery specialists in the county that we fund, and they'll connect them to that person, so that person's kind of keeping an eye on them, keeping them engaged. We'll bring them to our recovery centers. We have 3 of those in the county. Just kind of keep them motivated to go into treatment until the bed's open. And I think for the 1 person, it was the next day that the bed came open.
Because I know from my experience in the hospital system that it's not always easy to get somebody into a treatment facility, and they may very well sit in a hospital bed for 24, 48 hours waiting. Where are they going to go if they come to the police department? Are they going to sit in the police department?
No, they'll be back home. And that's where we're going to put the certified recovery specialist in.
In the home?
They can come to their house. They'll tell them about the recovery centers.
Okay.
They're not going to stay with them 24/7, but they're going to check in on them.
Okay.
It's not possible for us to do that. Even with the hospital with host program, if the hospital is ready to discharge and we have no bed, same kind of procedure. The host program is going to say, here, let's get you a certified recovery specialist. They're going to check in on you, keep an eye on you. The case managers are going to keep an eye on them. All we can do is kind of try to keep them engaged, because unfortunately bed shortage is reality in the state.
course, it seems like in our area and around the country that it seems like it's only getting worse. Is there any state or any municipality that seems to be, finding some solution or getting ahead of it at all? Or
Not that I'm aware of. I think when I go to my meetings, every SCA is in the same boat. We're doing a lot of work and we're doing a lot of good things. The numbers are still growing, but we like to look at it as how would the numbers be if we didn't do these things.
Sure.
They could be even worse. But I think the biggest thing is you try to stop one thing and something else pops up. You think you got a handle on this drug and they're creating stuff 100 times stronger, and people think they're invincible, and you get fentanyl and carfentanil and all that. There's nothing, not even Narcan, we're putting Narcan out there, and there's nothing they can do.
And I guess the second part is, how many of these addictions do you think spawn off of mental illness and untreated?
I don't have numbers. I would say that a majority of what we do, and the blessing, I guess, of the human service building is a lot of our individuals are co-occurring. You'll see it in our drug court. So we're treating both. I don't think it's just from that, but I think if you look at the majority of the people we treat, they're co-occurring.
Okay.
The only other thing I was going to talk about, I'd like to give a plug to our recovery centers. We do have 3 in the county. We have more than most counties, and I'm very proud of that. We have one in Easton, one in Bethlehem, and we have one up in Bangor. And they're just facilities that they offer sober activities. They have AA meetings, NA meetings. A lot of the certified recovery specialists work with clients out of there. Our drug court runs recovery support program, a group that meets weekly. They meet there as well. So they've kind of been a multi-purpose facility. So we're very proud that we have them. And if you want a drug court update, I can give you one of those. I don't know if you've
Sure.
had one lately.
Yeah.
As of this morning, and it could have changed because I was at the press conference and didn't make it to drug court, we have 54 active drug court participants. We have at least 8 pending applications, and I'm sure there are more. We've added a 4th case manager to our division. 2 of the 4 are dedicated solely to drug court, so they're doing intensive case management. And then myself, my assistant administrator, and the 2 case managers, we sit weekly on the drug court treatment team. I also sit on the mental health treatment team because there's so much crossing over. So we have a whole rounded perspective at the table. And we've had 9 graduates. We have 1 coming up again. And while in the program, I just want to state some of the things that they get. So they're assessed, they have treatment, they see the judge every week, they have a PO. Everybody has a certified recovery specialist that works with them, helps them get a job, teach them how to ride a bus, get insurance, just someone that they can kind of confide in. And then we run these recovery groups. So every week they have to report there. It's run by the TCAP case managers. It's not probation's not there. The judge isn't there. It's kind of their time to get together, call each other out on things. We have that, and now we're adding an alumni group because our graduates are growing. So we're going to start an alumni panel. It's going to be used, I think, if people are having trouble, we can bring them to the alumni group to say, hey, this can be you. He's a shining. We have so many great stories of our graduates, and just a plug for Judge Daly. He does an excellent job, and I can't say enough about him and what he does for us. So that's all I have, unless you have other questions.
How is the department running? Is everything running smooth? There's any needs that are going?
In drug and alcohol, I like to say we are running very well.
Okay.
I have to, give a plug to Allison, who's been great, very supportive of all these initiatives I'm coming to her with, always letting me kind of think outside the box. We're fully staffed. For us, that's 4 case managers, an assistant administrator, myself. We're hiring our fiscal officer. She was promoted, and so we're going to be interviewing on Monday for our replacement. But other than that, everything's great. Budget's closely watched. Funding that we need, we're able to meet, do different things in the community, which was excellent. And we're just rolling with whatever DDAP gives us.
I don't have any further questions. Anybody? No? Okay, thank you.
Thank you.
Appreciate your work. Okay, that was the last item on the agenda. Motion to adjourn? Second? All right, adjourn.
Across the hall, we have the